Call to order the March 28th meeting of the Central District Health Board. I'm making a little bit of a change. I think we're going to start doing a silent roll call. So we'll just have her count heads and move on. The next item is the agenda, and I'm changing that a little bit. Without objection, we'll approve the agenda as presented in the packet. Any objection? All right, then the agenda is adopted. Next item, without objection, is there any concern about the minutes from last month? Seeing no objection, we're going to approve the minutes from the February 24th or 21st meeting. Next on the agenda is our financial review. Well, welcome, and you've got the floor.
Look at the February budget to actual report. Report goes through the end of February of 2025, and Dustin will be pulling it up on the screen. This report represents so far about 67% of the fiscal year. There we go. Got page 1 up on the screen. A revenue overview shows us that of our total budgeted revenue of over 17 million, our actual revenue received so far at this point in the year is 13.2 million, which is a 76% rate of what has come in so far for our revenues. The big difference from the report from this time last year is that we received that second Ada County payment. So you can see that brought us our county contributions up to 98% of what we expect to receive throughout this entire fiscal year. So that shows us ahead of our planned revenue amounts at 76% when we're just at 67% through the fiscal year. Continue to see some differences in what we received in contracts from what we expected, but overall right on track with 66% of contracts received for the year. Our other amount where we see the big increase in community environmental health of having received 108% of our expected budget is from opioid funds, which come to us directly, not through health and welfare. So those are reflected in that other category. Looking at our expenditures, our total expenditures were also budgeted to be at 17.3 million. And so far this year, we've spent just over 11 million, bringing us in at 55% of our planned expenditures so far. So just slightly behind by a couple of percentage points where we expect it to be. Our personnel expenditures are right on track. Operating is over by a couple of percentage points, and capital still underspent, as well as trustee and benefits. Moving on to page 2. You see the same information presented in a different way. Page 2 compares the last 2 fiscal years to this fiscal year. When we met last month, we talked about the fact that we were a little bit behind in our fee reporting. We were missing about 2 months worth of our fee revenue. We got mostly caught up, but we're still a little bit behind in what we have actually received for fee revenue. So some of that is still not categorized correctly. I talked to Conan yesterday, and he thinks there's still about $1,000 in fee revenue that is not represented through the end of February. As I explained last year, we have had a staff shortage throughout this fiscal year in finance. They were able to get somebody hired who came to us with a lot of LUMA experience. So we're really grateful to have been able to get a full team in the finance department. We also hired a contractor who's a former employee to help with some of the training that was lacking and getting those fees adequately categorized. So between those 2 things, by the April meeting, we should be fully represented with what we've actually received in our fee revenue. Our contracts continue to show a little bit of a reduction from where we were last year and a big reduction from where we were 2 years ago. That's primarily attributed to the difference in receipt of COVID funds and gone back to what is more normal for that receipt. Contract funds, we talked about on page 1, personnel costs are slightly under budget, operating costs are just over budget, and our T&B and capital are both under budget. And those can come in different times throughout the year. They're not always incremental, so we don't see a steady increase in those throughout the year, depending on what the expenses are. Looking at page 3, our cash balance statement, with that receipt of the Ada County funds, our total cash balance at month end has gone back up to 12.7 million. Most of that is allocated or designated to our restricted funds of projects. Not any big changes to call out on this page. For our environmental health system upgrade, starting next week, we've got 24 hours of training scheduled for our entire core team. And throughout the past 2 weeks, they've done 30 to 40 hours worth of training each that were self-paced. Next week, it'll be the first live synchronous training that they do. So again, by the April meeting, we'll see more staff time bringing that special project or remaining amount down. We've also received our first invoice from Excel, so we should see a change in the balance there before next month. Employee retention was spent out in January. Our CDH staffing needs continue. We continue to have spending there with the hiring of the 1.5 home visitors for our home visiting programs. Reminder on the Armstrong bathroom remodel that we decided to continue to wait on that. We put out to bid. We only received the 1 bid. We would like to put it out to bid again after we update the purchasing policy, if we're able to do that at today's board meeting, and hopefully try one more time and this time get at least 2 and hopefully more bids so we have some basis for comparison. And the McCall office refresh has not begun yet. We plan to start that before the end of this fiscal year, but it may or may not be complete before the end of this fiscal year. Our facilities manager will be meeting with them next week for the planning part of that. So that brings our total balance of special projects to just over 700,000. There have been no changes to our reserve fund, our personnel reserve, operational reserve, or capital reserve. So total reserve fund designations at 6.5 million, and then restricted funds of almost 4 million, which leaves us an undesignated, unrestricted balance of 2.3 million. Of our budget actual report.
Yes, Mr. Chair and Laurel, I know I keep asking this question, but on the operational reserve funds, we approved that, what, 3 years ago? And that figure has remained static, even though costs have gone up. Do we need to be looking at that, or are we still okay? Because I would expect this number to change.
You were right. We did set that amount 3 years ago, but we have been adjusting it in the August meeting when we actually vote a project. So we have adjusted it upwards to account for our increasing budget. So we are at where we need to be for a 3-month cash flow at our current budget.
So I don't mean to be repetitious, but
that's okay.
Asking that question.
Yeah, you're right that is when it was said.
Yeah. Okay. Thank you.
All right. Anything else for Laurel? She got to experience the fun via technology last month, but let's welcome Commissioner Caldwell in person for the first time. Then next up, we're going to talk about the opioid settlement, and now Curtis has the floor.
Just a moment. Thank you, Chair. I'd like to introduce Becca Jenkins. Becca is our program manager for health policy and promotion, and she will be presenting and sharing the information on our opioid settlement funds. This was a request of the board for the last meeting, and she's put together a great presentation and has all of the information ready to share with you regarding what we've received today, what we've done with those funds, what we anticipate doing with those funds, and how we anticipate spending those funds in the future. So back over to you.
Mr. Chair, members of the board. Third time's a charm. I've been on the agenda to talk about this 3 different times. The first time I got COVID, second time I got the flu, today healthy as a horse. Thanks, Curtis, for filling in all those other times. Really excited to talk to you about sort of what we've done and our plan moving forward and some of the projects we've got. Dustin, can you move to the next slide, please? So to date, as of last week, because we received a deposit of $103,000, we've received just a little over $4 million in opioid settlement funds so far. In FY '25, our original request to the board was $425,000. And then during revisions, it was approved that we can move that up to just over $775,000. So there have been a lot of requests for community partnerships and help and ways that we could get the money out. So we were so excited to be able to increase those funds. And we came together yesterday to sort of figure out what our proposal for the board will be this year. And it will be right around $1.6 million for the year. It'll be mostly broken up, probably 50% personnel, and the rest of it will be in operating. And we're doing something differently this year. Most of that money has always been housed within my program as part of the substance use disorder and behavioral health program. And Courtney Boyce, the program manager for that, has been overseeing it, but we are now spreading it amongst the entire agency. So Beth will get her own project codes to work on some of that. And so we're really excited to have this sort of concerted effort throughout the agency to increase that budget request and try to sort of diversify our approach for what we're going to do. Next slide, please. So last year, when you heard from Curtis, we were really just focusing on the prevention and treatment side and working on MOUD, which is medication for opioid use disorder. And we were spending most of the money and time in the clinic trying to get the clinicians trained up in that. But we are now able to diversify and really expand the prevention spectrum, which is really exciting. So we're going all the way upstream into the treatment and recovery realm. And then we're also doing some special projects with the funds as well. So the next few slides, I've broken it down between what we're doing in upstream, secondary prevention, and then treatment and recovery. For the sake of this presentation, I've just listed the dollar amounts that we have subvented with these particular partners, and I'm just going to kind of tell you what those partners are doing for us. First, one of the most exciting partnerships we've been able to develop is with Communities for Youth. Communities for Youth is an organization that really goes into communities and surveys them to find out what they feel is missing in their own community. It's not a youth survey. It's specifically for parents and for adult partners to sort of figure out how they can better support the youth. It's an organization that is based out of Boise State University with Dr. Megan Smith at the head of that. And St. Luke's is working on funding the infrastructure for that locally. But in conversations, we recognized that they needed more staff time. And so we've been able to dedicate one full-time person, her name is Heather Allen, to do the work as a Central District Health employee, but working with Communities for Youth. So they're doing a lot of data collection, a lot of data walks, so parents can really understand what's happening in their community. And then they're using an evidence-based prevention model called Icelandic Prevention Model that really focuses on substance misuse prevention and mental health. It's really exciting. The Communities for Youth is all throughout the state in several different towns. Marsing is a really great example of how they've implemented that. Their superintendent was really fully on board. They're also a community school. They use a great suicide prevention program called Sources for Strength. And that's kind of the model that everybody wants to get to. They're just doing really excellent work. And the principal from Marsing was able to present at a recent conference to talk about it. And that's what kind of piqued my interest. So we're really excited about that. That's definitely one of the biggest partnerships this year. Next slide, please. Some of the other upstream prevention activities we're doing are parent education and family resources. So we're working with an organization called Committing to 16. That title is indicative of encouraging youth to wait until they're 16 years old to have phones and or social media. It's a parent presentation that we do at schools. There are typically 4 participants. So there's a nurse practitioner. She actually started this as her practicum for her degree, which is really cool. And it's just gained a lot of popularity. SROs presented this. We have a children's neurologist talk about the effects of social media and the youth brain. And there's also an FBI agent who participates in these presentations and really gives parents an understanding of what can happen when youth are using social media and how it can be. So we were able to fund several of those presentations. We'll continue doing that into the next year as well. Horseshoe Bend School District is also a recipient, and they're doing a lot of family resource and parent education around drug recognition, so they can sort of know what to look for in their youth. And so that's been really helpful. We've worked with Horseshoe Bend for lots of years, and it's always fun to be able to see what they can do. They have an excellent coordinator there who always has just the greatest ideas, so we're always excited to work with her. Idaho State University, we've given them some money for provider education, specifically around prescription drugs and opioid prescriptions. So they're able to get CMEs through those modules that they're developing within ISU. They're developing them and implementing them. We're just helping to fund the process. Ignite Idaho, which you're probably familiar with in Valley County, the Resource Center, they're doing some parenting classes. It's called Active Parenting. It's an evidence-based model. It's an 8-week or 8-session parenting course where parents and children go together and they have a family meal together. It's very similar to Strengthening Families, but it's a little bit shorter, which makes it a little easier to get families to stick around. So working with them on that. And then Pepper Shock is our contracted media company, and we have just some general marketing about a lot of these things that we're doing. So we've done some paid marketing around committing to 16 in order to get the word out. It's always really fun and exciting to be scrolling through Instagram and see ads about the programs that my team is able to implement. So that's been great.
And we go back to Idaho State portion for a second. Do you have any more detail on what they're doing or what the curriculum is for that education, provider education?
Yeah, Mr. Chair, I don't have it with me today, but I could definitely, the coordinator of that SEP grant, we can provide you with the reports. If they're,
You know, that's a pretty big component, depending on the literature. You know, 40%, upwards of 40% of opioid addiction start with a prescription. And there might be a void in information with providers emphasizing or offering alternatives, non-pharmaceutical alternatives to maladies that typically are like, here's some drugs, let's mask it and call it good.
yeah,
And so if there is a way to have some input into making sure that emphasizing alternatives to the pharmaceutical approach, that would be.
Yeah, Mr. Chair, I know that when we when we grant sub-grants, we always want to make sure that they're aligning specifically with Exhibit A, which is that outline for how we should spend opioid settlement dollars. And so it is definitely an evidence-based practice in a situation like this, because they are the subject matter expert. We really don't dictate how they implement that, but we can certainly get the curriculum for you and have you review it.
Okay.
We do receive quarterly reports with the progress that they've made. So we could get that detailed. Other questions? Next slide, secondary prevention, please, Dustin. So College of Western Idaho is a recipient of funds, and this is likely a one-time fund, but they are working on getting trained in mental health first aid so they can implement that within their campuses. Mental health first aid is a pretty general suicide prevention training. It does focus a little bit more on mental health and specifically suicide prevention, which is nice. It is a 8-hour training, so it's not just like a basic gatekeeper training. It's a little more in depth, but it's not quite as in depth as somebody who might be answering hotline calls would take. But we're really trying to build capacity, and a lot of these, even with the upstream activities, a lot of these are probably likely one-time funding opportunities, because we're really trying to build capacity and make sure that they're sustainable at the end, so then we can use the money in further years for other folks. And then Trivium Life Services, that's a local recovery and treatment organization. They used to be just up the road. I think they've moved now. but they're doing a lot of overdose rescue supplies. So on the screen here, you'll see this purple box. We call those Barney boxes because they're bright purple. And they have naloxone and overdose education in those boxes. So it's like a paper box. You can just open it and take it out. We've just provided the boxes as part of the sub-grant, and then they are responsible for refilling those with the materials that they need. Next slide, please. Moving into the treatment and recovery activities. Behavioral Health Group, again, a local recovery and treatment organization. They have what they call a harm reduction vending machine. So it's within the treatment space. They have different items in there that people can take for free. We are able to receive an old vending machine from Health and Welfare. So they used to maintain the contract on that. We've worked to now be able to take over the service of that, and had all the fun experience of trying to get a vending machine hooked up to the internet and all of those fun things so people could punch in a code and get things out. So that was a very good learning opportunity for sure. Transferring of ownership for that took quite a while, but we did it. And then we are expanding our CHEMS program in Valley County. We had been doing that with the Get Healthy Idaho grant previously with funds from DHW. That grant is ending in May. It was set to end in May regardless. And so we were trying to figure out how we could expand the program and extend it. It's been very popular in Elmore County, and Dr. Rhodes is at capacity. She's recently taken on a supervisor role. So we needed to add some extra staff to help with seeing patients. So we were able to give them a little bit of money this year to help supplement a half-time person. And then we do plan on budgeting for that for next year to support the full 1.5 person staff, which is excellent. I mean, it's a good problem to have if it's so popular that you have the funding to be able to continue supporting it. And then again, Pepper Shark, our marketing company, that is specifically for an anti-stigma campaign we have been working on. We're going to continue that work, collaborate with the clinic, and sort of figure out next steps on what that's going to look like moving forward. Next slide, please. So some of our special projects are, we are doing an environmental, well, we're calling it an opioid environmental scan. We're working with Idaho Policy Institute from Boise State. We've tried very hard over the last couple of years that we've received this money to really use Exhibit A as a starting point and sort of figure out, but there are so many allowable activities. It's kind of like throwing a dartboard. And so it really made sense for us to actually work with a contractor and get feedback from our communities to figure out what we're missing, how other people who receive opioid money might be spending theirs, how we can collaborate. So those results will be available to us in, I think, June, which is really exciting. And that will really dictate how we do our next sort of 3 to 5 year plan once we know that. So this last couple of years has just been like, we see a problem, let's give some funding, let's utilize the money. But now I think we'll have a really solid plan of what this is going to look like over the entirety of the 18 years we'll receive this money. The other special project is just having Sharps kiosks. We have several of them around within our entire district. We have one here at our building. It's on the far right side at the end of the clinic on the side, which is exciting. So working with the city of Boise, Boise Fire, the various cities within our jurisdiction to get Sharps kiosks up. And then we have been also doing assistance for counseling services for folks who want to see our counselor here on site, Andrea, related to their MOUD, so medication for opioid use disorder appointments. And we've also been able to set up a pot of money to help those who are uninsured or underinsured be able to help pay for those appointments. That is part of the funding that will be now moving out from under my umbrella and under HPP and over to Beth, which will be nice to have her providers have some input on sort of what that looks like. Next slide, please.
Pause for 1 sec. So
Sure.
how are people finding out where the sharps containers are and how often are we having to change them out?
That's a great question, Mr. Chair. We have mixed up your two names, Dr. Virgin, Mr. Virgin, Mr. Chair.
Is any sleepover?
We actually have an asset map. It's on our website and we can provide that to anybody who's interested. So we actually have all of those. Same with the Barney boxes. We have all of those things located on a map. We've worked with our team here to put those available. They should not have to be replaced, though it's not impossible. We actually did have one that wasn't previously owned by us down near the new fire station here in Boise that's down by Road Skate Park. Somebody did try to vandalize it. They were unsuccessful in getting things out of it, but it was damaged. And so we've actually taken over ownership of that and we're replacing it. But they are pretty sturdy and they shouldn't be. It's kind of like the impossible happened with that one. So hopefully those are one-time purchases and the information on where they are is available.
But as far as getting them emptied, how fast are they filling
Oh,
up?
yes. That's a good question. We don't really know the rate because these are all very new. Somebody on our team has been trained. We have 2 people actually in our drug overdose prevention program are trained to do that. But part of the sub-grant agreement is typically that the folks who are putting it on their site, they have to be responsible for the cleaning. But we can go and do that. We've done it. There's one out by the Ramada Inn. I think that may have changed names, but out by the airport. And then we can bring the biohazard litter back here to the office and dispose of it properly that way. So TBD, I guess, on how quickly, but we definitely check them every month. Yeah, but again, it's the responsibility of the person who's subcontracting with us to check those.
And how are we emphasizing the use of them? I mean, are people really going to be inclined to go out of their way to find a box or just pitch it?
So, yeah, that's a great question. And we actually did quite a bit of research and that was part of some initial interviews and part of this environmental scan to actually figure out where the litter was happening. So we sent out a syringe litter survey to most of the community. We actually got a couple hundred responses, which is crazy. You never get that type of response rate. And so we were able to figure out where people were finding them and put the boxes there. So hopefully they'll now see them and utilize them. We are certainly leveraging all of our existing partnerships. These are 3 consortiums and coalitions that we facilitate here at CDH. So the Valley County Opioid Response Project, and then we have health coalitions in Boise County and Elmore County. And they have been really instrumental in their work. It really helps expand what's happening. They're not necessarily using the opioid settlement dollars for funding, but what they're hearing and doing out in their communities with these coalitions really helps inform what we can do with those funds. And then locally, there's the Meridian Anti-Drug Coalition, and they have been a really fantastic partner. So we don't facilitate any specific Ada County coalition because there's lots of them, and we don't really need to add to the list, but Meridian Anti-Drug Coalition has been a phenomenal partner. I've worked with them for years and years. They work in the realm of suicide prevention, behavioral health. We always have drug take-back days events with them. So they've been really awesome in sort of letting us know where we might need to focus our attention within Ada County. Next slide, please. So as I mentioned, our next steps after we get those results back will be to develop a 5-year action plan, strategic plan around spending the opioid settlement dollars. It can be a little more than just throwing the dart and really make it strategic and actionable. Continuing to work in the multi-sector realm and over the full prevention spectrum. So really upstream all the way up to treatment and recovery. Upstream is where my heart has always been. I think it's so important because we want to stop youth from getting to the point where they need to be in treatment and recovery. It's impossible to catch everybody, but if we start young, then we can hopefully lessen the impact. Again, extending programs. So like I talked about with the KEMS program in Elmore County, and then we're also going to be requesting funds to help support the Nurse Family Partnership Program in this next fiscal year. Much of their funding has ended. Some of that was through ARPA, other federal funding. And so the opioid settlement dollars is a nice fit to that because it is we consider it to be a prevention program, and it could potentially be an intervention program as people are in the homes. So we're working with their manager, and you guys heard from Lisa, I think last month, right? So you would know all about how great that program is. And then just really continuing with community partnerships and the sub-grants that we have. We usually open those up as sort of a open application period at the beginning of the fiscal year. We offer mini grants, so usually $10,000 or less. Some are larger. Some we have, just ongoing conversations with partners and try to figure out what they might need, but we do have an open and competitive application process, and several of us review those applications as well. So trying to make sure that we're hitting all parts of the spectrum and work with as many community partners as possible. That's it for me. Any questions?
Yes, Mr. Chair, Rebecca, thank you so much. But I was wondering on your community partnership with your program extension, will you be doing referrals, working with the county jails? Will you be working with like St. Al's acute psych unit, Intermountain Hospital? Will you be working with them?
So, Mr. Chair, yes, we do quite a bit of trainings with them. None of those specifically have been identified as potential partners, but we probably would have interest as we open up the application process. But at this time, unsure what that looks like.
And another thing I was wondering about is ISP keeps track on the major highways coming in with fentanyl and how that is changing. If we can follow that somehow.
Yeah, Mr. Chair, it is changing. We have learned recently that overdose deaths are actually going down, and fentanyl overdose related deaths are going down, and they believe that it's because of programs like these and probably the opioid settlement dollars being available to so many folks and really focusing on upstream prevention and things like that. With the not with opioid settlement dollars, but with our drug overdose prevention dollars, we've been able to purchase the fentanyl testing strips, which is really helping. And so we've been able to give those to law enforcement partners. Now that those are, the statute changed this last fiscal year to make those allowable. So we actually have lots of those. We also have xylazine testing strips and kits to show you how to, use those. And we, as part of our drug overdose prevention program, one of our required deliverables was to start up a FAST team. It's public health and safety team. So we actually convene public safety partners here every month. Again, not related to opioid settlement dollars, but related to opioid prevention. And lots of overlap. So we're getting a lot of great feedback of what they might need in terms of resources and education. One thing we're working on with them is developing a resource guide on if they were to respond to an overdose death or a non-fatal overdose, sort of what the next steps might be for them to provide resources. So that could include testing strips, recovery services.
Would one of those partners be law enforcement and supply things coming into the state?
That's a great question, and I don't know the answer to that, potentially. The FAST team is new this year. We've only just started it. I think we've had 3 or 4 meetings, but I don't see why that wouldn't be a part of the conversation moving forward. Yeah.
Sure. Thank you, Rebecca. My great question, because that was the same question I had. In terms of the testing strips that you're using, are they the wet or the dry?
Sure. They're the wet strips.
Okay, because I'm aware that there's newer products that's safer for both teams and law enforcement in terms of you don't have to make a liquid slurry and put, we can talk later about that. And then the other just interesting scientific question would be, with all of our collection sharps and whatnot, would be trace testing those for amounts of fentanyl from waste products, because that would be a good monitor of how much fentanyl is or isn't coming into those disposal boxes. That would give us an idea, and law enforcement an idea of present within the community. And then the final question would be, are we working with the juvenile facilities as well as the jail facilities to see, what the stats are on abuse disorders in that younger population as far as it goes with the education program and the school programs.
Mr. Chair, I'll answer your last question first.
Sure.
We have worked with justice involved folks quite a bit, including doing trainings. So that way we can train the officers to hand out kits and better inform folks as they're coming out on the safety of so just to ensure that overdoses aren't happening. In terms of juvenile justice, that's not a connection that's been made yet. It's a bit tricky with, of course, juveniles. And also we're not seeing incredibly high rates of opioid overdose among youth. Not to say it doesn't happen, and not to say that opioid use disorder doesn't happen with youth, but it's really amongst adults. So the primary focus with a lot of our sub-grants has really been on the adult population and juvenile. That may change in the coming years. And then to your second question about the testing, I think that's a great idea, and I don't know exactly what that looks like. I think that would probably have to be a conversation with law enforcement, and of course, there's always a safety issue of trying to actually test a shark. Make sure that everybody is safe in that situation. Yeah, yeah.
Thank you.
Is there any further interrogation of that?
Thank you. Are on top of it. It's awesome to see and to see all the pictures and the ways that you're approaching it. Thank you.
Thank you so much. I'm excited about it too.
That must be the ghost of a disgruntled staff member.
It needs to dry their hands. Thank you so much, Mr. Chair. Thank you.
All right, very good, thank you. Next on the agenda is the vote on budget guidance, or and that's from Russ.
Yeah.
Taking that one.
Thank you, Mr. Chair. So some of you have been through this process a lot of times, and Commissioner Caldwell is brand new. So our fiscal year is always aligned with the state fiscal year. So it starts on July 1 and it's June 30th. And I know that's different in the counties. Historically, we received about 15% of our budget from the state, 15%-ish from the counties, but that's all been shifted over to the state with House Bill 316. I'm sorry, all been shifted over to the counties with House Bill 316. But nonetheless, we're on the state controller's office finance system, and it continues to work well to stick with the July 1 fiscal year. So process is today I will talk about what I would like to see in terms of the contribution from the counties and ideas around our compensation plan for our staff, which will be implemented around the very first pay period in July. Sometimes we do it sooner if we have carryover money with authorization from the board to do that. So I'll present that, and then on April 18th, which is our next meeting, we'll present a draft proposed budget to you all for approval. And then between that date and May 9th, when the budget committee will meet, and this year it's here. So Chairman Beck from Ada County will chair that meeting, and then the chairs or their designee from the other three counties will participate. So that's May 9th. Between April 18th and May 9th, I go around and I meet with each of the Board of Commissioners. Many of you participate in that if you're not already there as a commissioner, which I really appreciate. Just to basically talk about the things that we've done over the past year for your particular county and answer any questions and go through the budget. So that's the process. Once that budget is approved, if on May 9th, the budget committee approves it, and that's when it'll begin essentially on July 1. We've never not had a budget approved, but if it for some reason the commissioners didn't approve it, and we'd have to go back, not completely to the drawing board, but we'll have to make adjustments to that and re-present it at a future meeting prior to the start of July. So I guess looking back in time, I've been here for 19 years, and pretty much every year we've asked for a 3% increase from our counties. And the idea is to try to keep pace with inflation. About 70% of our budget is personnel. So in order to continue to increase our staff salaries to be competitive in the labor market, that has worked well for us. A larger portion of our funding, so the county's a little over 30%, a little bit more than 50% comes from federal funding, comes primarily through the Department of Health and Welfare. And we don't know how that's going to play out just yet because their budget has not been finalized. But the county portion is really important because it's such a big component of our budget. There were 2 years where we didn't ask for a 3% increase, and that was during the recession years. We asked for basically no increase at all, and then we got back on track with the 3% increase. Part of it is too, I think there's that consistency. You know, sometimes the economy is doing extremely well, which is generally doing quite well now, but we still keep our request at the 3%, and we've never asked for more than that. So that is what I would ask as far as guidance from the board, which is what this agenda item is about, to build a budget with a 3% increase from our counties. More specific to that, before I go on to the comp plan for staff, is that doesn't mean that each county will contribute 3% more than what they did last year. It's based on a formula which is set in Idaho code, and it's essentially market values and population. So usually, like for Ada County, it's because the contribution is about 90% of what the counties give us in total. There's changes like from 2.9 to 3.1, 3%. Other counties can see pretty significant changes. Valley County being one. I recall before the housing recession hit, it just kept going up and up because market value had changed so much. And Boise County, I think, in recent years has been seeing that too. So just for clarification, it's not just a 3%, it's a 3% overall shared based on that formula. And you'll see that in the budget we present on April 18th, how that will specifically impact your individual counties that you represent. For the compensation plan, one of the things we did in December was get approval for our compensation philosophy from the board at the December meeting. And we have historically adopted the changes in pay ranges using the state system. And we continue to use the state system, even though we're no longer under the State Division of Human Resources, but it doesn't make sense for us to try to create, or it would be quite expensive and ongoing cost to do our own analysis and adjust pay ranges for, I don't even know how many job classifications we use, but we have about 150 staff, but probably 40 or so different job classifications. So we continue to use the state system, but we haven't always been able to keep up with the changes that they've made, and we're waiting for the legislature to approve the new pay ranges. But we're going to adopt, or through the agreement we had with all of you in December, what Korn Ferry, that's the company that does the analysis for the state, what they're recommending for fiscal year 26. So to go from fiscal year 24, which is what we used for last year's pay increases, to fiscal year 26, it's going to require a pretty significant increase in pay if we keep our staff at the same pay, the pay they're getting within the 24 range. So if they're at 85% of midpoint, And we moved them to FY 26, 85% of midpoints. That's what I say is just keeping them whole. They're not necessarily adding, but keeping them within the pay range at market rate. I don't know, the 3% increase from the counties, if that is approved today, plus any changes that may occur with federal funding, if we're going to be able to do that. But that was what we talked about with our executive leadership team, which is Beth, Laurel, Curtis, and myself. We would like to do that as our first step and try to move proportionally everybody within their job classification pay range to keep them at least at that same level. And we'll know what we can do once we see what guidance comes from you, and we go and we build the budget, and then that's what I'll present, describe it in more detail when we get together on April 18th. Last thing I'll say about that, one of the challenges that has occurred in the past is if the state doesn't adopt the new year's pay range, you just get further and further behind, and it's harder to catch up. And that's why I think it's important for us, whatever the state does, if Korn Ferry says this is appropriate for a medical assistant, this is what you should pay them. I think we need to try to keep our staff in alignment with those pay ranges as our budgets will allow. So my request is for guidance from you all today as an action item, the county contribution, and then the idea of moving our staff as much as we can to keep them at the same percent within their respective pay ranges. And last thing, you'll have the opportunity to obviously decide whether you want to approve that budget in April. So what you tell me today doesn't mean that's going forward to the Board of County Commissioners. It will be depending on your approval at that next step. So less than a month.
Do we have any idea of what the raw numbers look like if we consider 2.5, 3, 3.5? Is there a way, is that calculable? With the unknowns of property values and things. So do you have a guess what 0.5% means in broad dollars?
Laurel may have a guess. I would have to look at the budget to see exactly what it is.
Yeah, it probably would be a several $100,000 difference, depending on if you full or half or how it calculates out. We can, in past years, I think 2 fiscal years ago, maybe 3, we developed 2 budgets, a 3% and a 4% at the board's request. When it came time for the April meeting, they didn't want to review the 4%. By the time that month had passed from March to April, it was decided, let's just stick with what we've typically done, go with the 3%, review that. It's a lot easier if we only prepare 1 budget than 2, because you really do have to change all revenues, expenditures. We'd be looking at changing what staff would receive if we prepared 2 completely different budgets. But in terms of numbers, a 0.5% difference one way or the other would $100,000 range probably.
Yes, I mean, I think the challenge we face is there's known knowns and knowns and unknowns. And the known unknown right now is the fact that the housing market is in a bubble, so property prices are probably going to take an adjustment. Boise is unique in the growth compared to the rest of the nation, so we don't know what's going to happen here. I mean, I would hope that we can just stay at that same state adjustment and propose that with the knowledge that going forward, may be into an economic bump for a year as things adjust. But I mean, if things are stable for now, then we do what the state does.
Mr. Chair, we do have the property value and the population numbers already, so that part, Conan's already been able to figure into the matrix of what we anticipate for next year, for this, yeah. Going forward, like you said, hard to predict, but for this year, we received those numbers about 2 weeks ago.
The 3% talking about cover keeping them within the range that they're currently in as we move forward, like what you're talking about. Where everybody else is.
Mr. Chair. Probably not. I don't know that we'll have enough money with the 3%. And again, it depends on what happens with a lot of the federal funding streams. If they stay level or they're decreased, it would be probably next to impossible to move everyone. If you have to move 4% or 5% to get everyone to move based on how much their pay range has changed. So that's the answer is 3%. Based on it's a little less than 31% of our budget will likely not allow us to do that full move this year. Yeah.
What an increase to the counties. Their employees.
Mr. Chair. So we have that actually, and I didn't bring it for salaries. So we, I can actually get that if we take a break, and bring that back as well as the number you asked for. And that's an option too. If you want to pause on this and we can take a quick break and we can get that information to share with you. So that's something to your question, talking about staff salaries, so that we look at what our 4 counties do for their staff each year, and in April, share that with you all when we have a more definitive plan, comp plan based on the budget guidance. And our philosophically, what we tried to do is stay reasonably in alignment with that. It's not going to be exactly, obviously the same as Ada County or Boise County, because you all do something different for your staff. But that's something that we've worked really hard to not get too far out ahead or too far behind.
Kind of on that note, Boise County, our employees were so far behind, we couldn't hire anybody, we couldn't get anybody to apply for a job. And we were so far behind, it's taken us 2.5, this will be the 3rd year of trying to get caught up, and we can't with our budget increase. We can't just go where they should be. But I think the first year we got 80% of their salary raises, and then that next 20% still hard to. But we're getting closer. We're a pretty conservative county, and the employees kind of got left behind, and it's really hard to get caught back up. It just put us in this place where we couldn't even get somebody for a road department. And so getting behind is hard to make back up later.
Do we have any assessment as to what the job market is like now in some of the kind of key job descriptions? Are we having a hard time right now finding or filling?
It really depends on the position. Beth's been trying to hire a nurse for what we put it out 3 different times.
5 right now.
Okay, so 5. And sometimes we have no one even applies for those with the pay range that we're offering. Some of the other positions where we've seen a little bit of an uptick in interest, certainly a lot better than we were in like 21 and 22. So I think that's the best way to describe it. It varies depending on the position type.
Mr. Chair, I'll also add that in our or lowest pay range job classifications is where we see 75% of our turnover. We looked at it for the past fiscal year. And that pay ranges are where people can go to almost any other job that doesn't require any qualification and receive the same or more salary. So we're investing a lot of money training and in turnover for those positions, similar to what Commissioner Tucker was saying, that we are getting an increased number of applicants, but their longevity with the agency has not been great, and their key positions are customer facing positions. And the FY 26 pay range for those positions gives those entry level positions a bump that would be where we would feel more comfortable posting those jobs. It's been difficult, I think, for us as the ELT to continue to post them at the FY 24 range, knowing that it unlikely will retain them very long, and the level of training that it takes for our clinical assistants and our customer service representatives is between 4 to 6 months of training. And we're finding that most people aren't making it through that time period.
We're getting a slight bit more of the resumes coming in for positions, but not with experience. So it supports what she's saying, that they're sort of just surfing.
Well, then let's take a 5 or 10 minute break and reconvene here in a minute, or 10. So, Dustin, you're gonna put us on pause? All right, we're reconvening and Russ had gone out and grabbed some information to share to answer a couple of the questions. So I'll let him have back at that.
Okay. So the questions were around, I guess I'll start with the budget side and then the compensation side, the two things we've been talking about. So last year, the total county contribution from all 4 counties, and this is obviously fully implemented with the transition from what the state used to pay to the health districts to be fully county funded, was $5,511,800. So if we built a 3% increase into our budget, it would be an additional $165,000 shared among the 4 counties. And before I go into 3.5, 4, 2.5, it's around $30,000. Obviously, if it's 4%, it's going to be for a 0.5% to go from 3.5 to 4. It's a little bit more than that. But I think if you think about for each 0.5% change up or down, it's about $30,000 difference. So a 3.5% would be a $192,000 increase from our counties. A 4% would be a $220,000 increase, and a 2.5% would be a $137,000 increase. So as we look at building this budget for next year, if you're thinking 2.5 or 4%, our base would be 165. That's what we've historically asked for with a 3% increase, and then go up or down for 0.5% by about $30,000. So I provided the salary increases for each of for what we did last year, which would have been implemented in June, and then each of our counties, as well as looking at the average increase over from fiscal year 21 through fiscal year 25. And that summary is at the bottom of the page. Questions?
I think you had a little bit of information that you wanted to add.
Yeah, I just wanted to be able to share, if you don't mind, a little bit about the impact that it's been to our team, specifically in the clinic side, with our difficulty in hiring. So for our WIC team, our clinical assistants, those are what Laura was talking about, lowest paid people. Currently, since I've been here the last 4.5 months, we've been recruiting for 3 positions, and it's been a revolving door the whole time. We've never been able to move past that 3 positions. And the downstream effect of that has been our processing standards and getting folks into WIC. So a new mom who contacts us, a pregnant mom who calls us, we're supposed to get them in within 10 days. And then someone who already has their child is within 20 days. And we're about 2 to 3 months out being able to get those folks in. So they're having to delay in benefits. And that's the direct impact of us not having be able to have those staff. And it's consistently, I hear from our teams, it's our salaries. Our salaries are so low, and the folks who are here because they have such a passion for what they do, or they have a significant other that's able to help support them with that. Another role that we're on our 5th round of hiring, we did fill the position, and the day before they're supposed to start, accept another job so that they can get higher salary. And then that just directly impacts the folks that we're able to see in the clinics coming in our door and being able to support that, which has then the impact of people coming in, as well as the impact on our providers having sustainable jobs. So then they're having to do the work of the nurse versus the level that they're at. So just some impact of 2 of the positions that I've been working closely with, trying to figure out how do we keep people and get them here, and one big component of that has been salary.
Well, I've seen it over 30 years, the cost of losing trained people. And that's a real expense. Has there been any thought to partnering with some of the schools that produce the educated people. There's a number of nursing programs in the area. Has Central District Health somehow like military, military can join up and they'll help pay your law degree or something.
Specifically with nursing, not currently. We do have a lot of partnerships with our NP students and with Full Circle and their medical students. Not sure if you have any more information about historically what we've done nursing wise.
And a registered dietitians, they do their, what's it called, like a practicum, they come through and sometimes we hire those individuals. So, and we had historically had the BSU nursing students coming through as well. But I think that's Dr. Young's point. You hire new, fresh out of school, train them, and then sometimes in as little as 6 months or less, they become more marketable to other patients. So, yeah. We've done national, we do national recruitments and different publications online, of course, and have had very little luck with certain positions.
So if $30,000 is the difference between 10%, then Ada County is 90% of that 30,000.
Right.
And their total budget is.
So Ada County's share last year of the total budget was basically of their part was 4.9 million.
But their total, like
Oh, I don't know.
27,000 would be what compared to all that they're having to deal with.
I don't know.
Seems like their budget is around $1 billion, right?
A billion.
That can't be right. I should.
So according to Google, Ada County's proposed budget for fiscal year 2025 is 391 million. So $20,000 divided by 390 million, that would be a pretty small percent.
Yeah.
Well, from my perspective, I don't think it's unreasonable to maintain the 3. Thoughts from anybody else, or does anybody have a motion? Are we dividing this, or are we just voting on?
I think the big thing is the county contribution, the salaries. I'd shared with you where we're at with that and what the 3% will do. And more clarification, not every job class moved by the same amount. Certain positions like IT and healthcare, even more. So Dr. Young, you would ask, are we going to be able to give people whole within their pay range with a 3%? And I think the answer is no, we won't be able to do that, but we were planning to, whatever we would back off from that, proportionally move everybody within their respective pay ranges.
Mr. Chair, I do have a quick comment. I know I was just talking to Commissioner Tucker about this, and I'm not sure how much Elmore County gets in SRS funds, but Valley County is looking that if it's not passed this year to drop from about $1.8 million of SRS, which is secure rural schools, go to our roads and school funding to about 250,000. Combine that with what the state legislature just did, where they kept a lot more money for state transportation funding rather than give it to the counties to the tune of about $10 million. we're looking at some serious decreases in our transportation funding. So I don't think Valley County at this point can commit to, I'm sure we will do the best we can, but we're even possibly looking at a road levy simply to fund our transportation. So the counties are in a tough, really tough spot right now, and it's really up in the air. You commented on federal funding law. That's where we're waiting. Our hands are tied until SRS gets passed, and it's looking like it's probably not going to. That's a pretty scary front for us.
Portion for Elmore County Highway Districts.
Commissioners will have to be out there shoveling snow on the roads.
Something like that.
So once again, we need a vote on a number, 3% or whatever the number is, in a distinct motion.
Well, Mr. Chair, the counties are capped at 3%. Yeah. What does that mean? That means that their increase, they cannot go above a 3% increase, correct?
Plus
For
new
their
construction.
employees.
Let's move, yeah,
Their overall budget
their overall.
is restricted to, they can't increase their budget by more than 3%, but it can include new construction. So there's a lot of growth happening, a lot more taxable entities, businesses, individual property owners, and it could go up more than 3%. And the public health part is actually levied. It doesn't show up on your tax bill, but it is one of the things the counties levy for. And all of our counties, and that's capped also, but none of our counties are even close to maxing out the allowable levy for public health services. I'm not an expert on it, but that's kind of the high level.
I don't have a problem with the 3% to prepare your budget. It's, I mean, like, commissioners know if we don't have money, I don't know what to do about it. Let's find that out later, I guess.
Again, if we do the 3%, that's what I'm going to present to you, and then you get to decide at that point in time, and you'll see specifically how it impacts your individual county when put a document together that looks like this. It'll say FY26 on the 18th.
All right. So that is an action item. And so, Commissioner, are you making a motion?
Unless anybody has any issue with the 3% number. So I will motion to have the Central District Health prepare their budget guidance at 3% increase from the counties.
Second.
Right, we have a motion to increase to 3% or prepare the budget at 3%. Is there any discussion?
Still really struggling with not being able to keep employees. Because if we don't have employees, then we can't be. We don't exist. So there's a part of me that still is thinking, even at 3.5, not that there's money out there to just be had, but it's just worrying.
To Dr. Young's point, I'm wondering if those non-retained positions that we're struggling with, going to do a carve out or, specifically just for those handful of positions that end up being that challenge to fill, that we internally do a focus on those particular positions to make those more market, those particular positions individually more market competitive. And that way it doesn't, necessarily apply across the board. But if there's a handful of positions, then just from having brushes and things like that, just look at those particular positions so that market-wise are hard to fill and say, okay, we're going to bite the bullet on these positions. We're going to have for improvement in that areas.
Mr. Chair. Yeah, that's something we can definitely do. We know what the positions are. And even with a larger percent increase, the dollar amount's less than your higher wage staff. So, and it's generally there's a few exceptions in healthcare, obviously, but for the most part, it's our lower wage job classifications where we're seeing the higher turnover.
So I would suggest hopefully we just have an internal discussion on that in terms of those positions. And really, value those so that we can retain.
Mr. Chair, on some of those, for obviously our Elmore County is a little bit higher than everybody, but we've really worked to increase our salaries. But for those positions where we had part-time filling, we actually did, and it was mainly jail and dispatch. But we had actually a recruitment. So if you were a current Elmore County employee, and you recruited somebody in, then you got a stipend. They stayed 6 months, then they get a stipend. And that type of thing. For those key positions, we couldn't get any applicants, and that, I think we're pretty much full staffed. I mean, we have some rotation, but those positions that we have, so that might be something to consider.
Yeah.
As far as, somebody else works there, then that sometimes they can speak to the organization better than anybody.
Mr. Chair, that's something we've done, like what a lot of other organizations with sign-on bonuses, and for Valley County, trying to recruit an environmental health specialist senior. I mean, I don't felt like it didn't matter what we offered. People didn't even apply, and I think it's just a very high cost of living, rural community. Obviously challenging weather conditions and all those factors. And so we do what we do is we recruit. If we don't get any qualified applicants, usually after the second time, then we start offering incremental sign-on bonuses. But I like that other strategy too. It's just trying to figure out ways to get people to apply and then get them to stay. We do that with the bonuses. You don't get it first day. You have to be here a certain period of time, but then people leave after that too. If you make it 6 months, 3 months, 6 months, frustrating.
Did we have salary money left in the budget that has been unused at this point?
Mr. Chair, are you asking if we have salary savings so far this fiscal year?
So what would have prevented us from using some of that savings to sweeten the pot for some of those positions?
So what we stick with right now, we've adopted FY 24's range that the state is using. During last fiscal year, FY 25, when we approved the budget, we did not move to the FY 25 state range, pay range. We stayed at FY 24, and we did a merit increase only. We weren't able to do both the move and a merit. So that's why we're in the position that we're in. We're 2 years now behind the state's suggested salary range for FY 26. So when we hire a position that's classified as a J or a K, some of those entry-level positions, if, for example, a CSR is being hired at that range, we have kept it that the clinical assistants who are in the same range get offered the same entry-level wage. We haven't so far picked and chosen if we're going to do something different from what the state range dictates, other than offering bonuses. What we've tried to do is have that consistency, and with the board's adoption of the compensation philosophy and guidelines, which stipulates that we will use the state's range, we felt like picking and choosing, even though we know those positions are hard to recruit, is difficult to do and stay within that compensation philosophy and guidelines. Some of the things we've talked about is just raising our starting point for the agency, even though the ranges may start below that, having a set salary that we don't go below. That's something we've discussed but haven't implemented. It also isn't called out in the compensation philosophy and guidelines. If that's something we would do with the board's approval, it's something we could consider. Don't know what that range would be as a base range, but be willing to talk about that. I think picking out individual positions it creates a lot of heartache with other comparably classified positions. So talk about, right now we have a full team of customer service reps, but we can't find clinical assistants. They're the same classification, similar types of job duties, and people are applying for one, but not the other. So if we pick one and say your starting wage is going to be higher, but we don't do CSRs because right now we're not having trouble recruiting today, then it creates a gap. So trying to figure out how to overcome those is one of the reasons we want to just use the state system and be able to move comp ratio to comp ratio. Another thing that the state did 2 years ago that we haven't done yet, but would like to do this year is they've always had just one pay range associated with each classification. They moved to separate pay schedules. So there's now a healthcare pay schedule, an IT pay schedule, and a general pay schedule. There's also a road or construction one that doesn't apply to us, but there's 3 that will apply to us, which call out so nurses will be in their own pay schedule. They won't be in the general anymore. Our IT team will be in their own pay schedule as well. So we feel as an executive leadership team that by adopting, if we are able to fully adopt that FY26 pay schedule and move to comp ratios, it does focus a lot on those entry-level positions. It focuses on healthcare, it focuses on IT. So the state's already done some of that position picking for us if we're able to make that move. The mid-level positions, we tend to be closer to market range. It's the higher pay classifications and the lower pay classifications that, according to the state's analysis and healthcare and IT, that have the biggest gaps for market value. And so their Korn Ferry analysis has already shown, Dr. Cole, exactly what you pointed out.
Thank you. Mr. Chair. So that's not specific to that, but thinking about salary savings, which Laurel was talking about. We you always build in a certain amount of anticipated salary savings based on staff turnover, right? Somebody leaves a job, give you 2 weeks notice, there's almost always at least a month gap. So you save money. And then when you have staff retiring, they're usually way high in the pay range, and then you bring newer staff in, assuming they don't have a ton of experience at a much lower wage. So there's salary savings there compared to what you budgeted. So when we talk about carryover money, that's usually what makes up the bulk of carryover we have. So after, again, having done this for quite a long time, is an option is that we budget in a way that would allow us to get closer to 0 carryover, with the risk that we would be in the red. But if you are in the red, you have $4.5 million in operating reserve that it wouldn't have to do layoffs or anything like that. It would just be budgeting closer to 0 and possibly needing to tap into our reserve account to balance the budget. So I know that's like, ooh, but at the same time, we have a really healthy operating reserve that would allow us to get us through that
So you're
period of
talking
time.
about that $4.5 million.
Honestly, you end up with $500,000 and an $18 million budget in carryover. Usually a lot of money, and we always have projects to do and IT projects and things like that are capital projects. But it's something I've contemplated is, that would have to be like if we were to move staff further in the range than we're going to be able to do if we ultimately get approval for the 3%, we could budget a little bit more aggressively the manner in which I described, because we're not going to be short on funds. We're not going to have to borrow money. We have cash available to do that, but I would just want to make sure the board understands that before we present next April or May and say, hey, we're $100,000 short.
So are you saying if we adopted the 3%, we could budget in a manner that would get us closer to the 26?
Yes,
Pay scale,
we could do that.
keeping people where they're at in the FY 24 and just moving them proportionally within that pay scale to the FY 26 pay ranges. With the 3% from our counties, and then this budgeting, again, more aggressively. You know, worst case scenario, right? You'd have a whole lot of, or no one would leave, and you're,
Delivery position.
yeah, which is a good scenario, but not from a budgeting perspective.
Chairman, so Russ, you're saying that, would that be designated under the special projects and carryover, and could it just be put in there as such that it's a staffing increase, or no?
No, we would. So when we build the budget, we would just
Put in.
in anticipation of less, you know, it's just part of what we figure in when we build the budget is we're gonna have a certain amount of turnover, so you have a 3.5% margin. I don't even know what the exact percent is. Year after year, we end up with carryover funds because we don't want to ever end up, have not traditionally ever wanted to be in the red at the end of the year. So, I mean, it would be a different approach than what we've used, but we have a really healthy reserve as directed by the board. And that actually legislative services office said you should have a 3-month operating reserve. And historically, we've been like 1 month, sometimes less than 1 month. Not that we want to talk about COVID, but that money actually allowed us to have significant savings because a lot of our staff, like me, I wasn't charging to county money. I was charging my time to federal money. And it's kind of like the ARPA funds for counties and for others that allowed that to happen. That's what really allowed us to bump that up to the point where it is today.
To that point, that may be an ability within the budget. You know, we're spending certain money on certain COVID products. Still, that could be shifted more to salaries and nursing or to some of those more targeted areas.
Yeah. Yeah. So that's something that, you know, again, we don't have to make that decision today, but I would tell you if we do the 3% and we want to try to move as far within those pay ranges, within that compa ratio for each of our staff, and potentially look at the lower wage earners, I think that's a way to do that, that on paper would look more risky, but in reality, I think we would probably be fine.
So basically you're saying, so with the 3% right now, internally with Floral Genius, we can make sure that we allocate in the areas that we need to do it. And so place proposal that's still on the table. Second, sounds pretty reasonable at this point to accomplish what we're setting for.
So does it seem like hitting that 26 mark how likely would we be to get to the risky tap into the, I mean, can it get close to the 26 and not be quite?
Based on the number, Mr. Chair, it's based on the numbers that we've discussed, we would definitely have to tap into the more aggressive budgeting approach in order to get closer. I still don't know that we would get there.
Mr. Chair, I agree with Ruth's assessment of that. I will say that also with whatever carryover funds and savings we have this year, if we're not able to get there, no matter how aggressively we budget, we don't have that anywhere close to program managers are still turning in budgets through today or their planned budgets. We could designate carryover funds and do a second round potentially of getting employees closer to that point in August if we're not able to do it in the May, June timeframe. In the past, up through last year or until last year, we have only used carryover funds for one-time funds. Last year, we successfully used it to support a couple of positions, knowing that we do always or typically have carryover funds. So even though it's fiscally responsible to use it only for one-time funds, since it's what we have left over at the end of the year, knowing that there will be some carryover on an ongoing basis, we have found success this year in using it to support salary for the first time. That's something we could consider in August again if we're unable to get there in May, June. But I think with the board's guidance, I'd be interested in working with Conan and taking a crack at getting as close as we can with more aggressive budgeting going into the budget prep over the next few weeks.
Okay, so we have Commissioner Tucker's motion on the table. The way I understand it, we're voting on the 3% county portion,
County contribution.
But we're kind of basing that on the understanding that when you go to create the budget proposal for next month, that we're going to be factoring in the conversation that we just had about using leftover carryovers and things to try and push towards the 26 schedule.
Yeah.
Is that what everybody thinks? All right, and if there's no other discussion on Commissioner Tucker's motion, all in favor say aye.
Aye.
Any opposed? All right, very good on that. So then, are we on to purchasing policy? Yes. Laurel's back up.
Mr. Chair. Okay, so you'd be wondering why you have purchasing policy in front of you and if it's going to be as dry as it seems, and the answer is probably yes. So historically, at the district, for our purchasing policy, we have adopted a purchasing policy that pretty much says we follow the state's purchasing guidelines, and that within the agency and using LUMA and the SCO's approval hierarchy, that's what governs our purchases. Our purchasing manager over the past year, through attending Division of Purchasing meetings and doing some additional research and looking at what we are actually classified as, which is a political subdivision, not a state agency. We should be following the purchasing and procurement guidelines for political subdivisions rather than state agencies. So the purchasing policy that you see before you references the state statutes that govern political subdivisions. As a part of that, it also stipulates that the governing board have a purchasing authority or have a role in purchasing authority. So with this new purchasing policy, what I would be asking the board to do as an action item today would be to delegate that purchasing approval to Russ, with it in the policy that we're following all of the statutes that govern political subdivisions. I listed the primary one, Idaho Code 6728, that defines and governs purchasing and procurement for political subdivisions. I also found through help with purchasing manager and from Conan as well that the Idaho Public Purchasing Association, IPPA, has an entire on what statutes govern all aspects of procurement for political subdivisions. So rather than try to pull out all the individual statutes and work them into our own policy, we decided to just put that handout in the policy as an attachment because it has them all defined and linked. As you can see flipping through, there are so many that touch what their requirements are for public works contractors and every other component that could possibly touch in any way our purchasing and procurement. So it's much easier to include their handout than try to recreate our own or include all the statutes separately. A couple of other things that we wanted to call out specifically are that CDH will endeavor to purchase goods and services from vendors with significant Idaho economic presence. That's also in the statute. Continuing to discourage employee purchasing with personal funds. And we also rolled our P card policy into this purchasing policy rather than having it as a separate policy, since using a P card is part of purchasing. The other change from what we've had prior in our purchasing policy is, can go to the last page, Dustin, attachment 2, please. It's tiny in your packet, but it is a procurement matrix. We got the basis of this from what Ada County uses, and just made sure it included the columns that were relevant to us. And this is an example that the Idaho Public Purchasing Association uses, as well as kind of the example of how to put a matrix together. They use Ada Counties. So for this, and it's still small on the screen, so I apologize for that. Russ probably has an extra pair of readers or two on his desk. So, but it governs what all of the thresholds are for services, goods, construction, design professionals, emergency purchases that we need to abide by, what levels of insurance are needed, who needs to have a public works license. All of that is clearly in one matrix. Those are a lot of the questions that would come up when we just said we follow the state policy. If we're doing a construction project, do they need to be a public works contractor, things like that. Now we put it all in one matrix where it's an easy reference point. And again, this is very similar to what the county uses for their procurement matrix. So to summarize the changes, we're going from following the state's purchasing guidelines to purchasing guidelines for political subdivisions, asking the board to delegate purchasing authority in accordance with those statutes to Russ. And then this will be a policy that, with board's approval, we can review annually or every couple of years. If the thresholds change, we need to update that matrix. We bring it back to the board at that time. We'll note that the policy that all of you have in your packets, except for Dr. Furch, have a spot for Russ's signature. He has one that has a signatory line with his signature on it, which we didn't realize till this morning that I had kept that final page with Russ's signature in the policy. So I apologize for that, but Dr. Furch does have the correct last page in front of him.
Chiefs, I turned that off, and I've got this app on my clinic phone system that rings regardless of what I do with the volume on my actual cell phone. Just to clarify, so we were using a policy based on we're a political subdivision, correct? That's what we technically are.
Yes, we are a political subdivision, very clearly defined in Idaho statute. We were using the state's purchasing guidelines of what our current policy as it exists today follows the state guidelines.
Okay. So besides the P card and a couple of the things that you already mentioned, were there any other big changes as a result of?
Mr. Chair, one big change is that according to the state's guidelines, the threshold generally for going out to bid was $15,000. Anything above that, if it was going to be that much over a 5-year period, the recommendation was to either go out for request for proposals or request for quotes. Following the political subdivision statutes, that threshold moves up to $75,000. So that is one big change. The other changes are more just what statutes we refer to in terms of governance. Another thing, the state policy really strongly recommends using all of their approved state contractors. We already had language in our policy that we didn't have to if it meant good business practice. A lot of times we can find things cheaper than they are on state contracts. So we always look there first and then do a little comparison shopping. So if it met good business practices, we weren't required as a district, according to our previous policy, to use state contracts. This takes out that looking at state contracts as a first requirement. We still have the option as a political subdivision to use state contracts. They're still available to us. But it just it gives us a little more leeway in looking at those Idaho contractors and vendors as we need to. It does change the thresholds, but it also clarifies a lot that we didn't have clearly in policy before.
So this brings us a bit more in compliance with the actual
Correct.
code and definitions.
Yes.
Okay. We need to approve this, so anybody be willing to approve that? Second,
Second.
very good. Any detailed discussion about the motion to approve this purchasing policy?
I would just note, I think the legislature is working on a new bid number and it's gonna be more like 250,000. So keep that in mind when they
Okay.
conclude
Pay attention. Yeah. Thank you.
the session.
Very good. Any other discussion? All right, all in favor of adopting the policy, say aye.
Aye.
Any opposed? Very good. We are rolling on to discussion about swimming pools. And Curtis, us are up.
Well, do a quick introduction to the subject, and Curtis can provide the content of what we're thinking. So, for some historical context, in Idaho, there was pools that were regulated prior to the year 2000 included hotels, motels, gyms, apartment complexes, and other facilities like that, as well as what we would consider a public pool, like a municipal pool where you go and you pay and you go to swim. A lot of those other types of entities were, if you lived in an apartment complex that had a pool, you're paying to stay there and you get to use a pool, the same as a hotel or motel or a gym. A pool is an amenity to the operation or the residential facility. So in the year 2000, the legislature changed that and shrunk the regulatory authority down to public pools only. So in our district, we went from over 200 pools that we would regulate. And when I say regulate, we go and we do an inspection, we look at all the documentation, we look at their training, we look at their chemical logs and things like that. And if they're not complying with rules, proper practices, then we educate, just like we do in childcare centers. We don't close pools. We've never closed a pool. So was it a step backwards? I mean, I think that, yeah, I think it was. And I will tell you why that came about, is that Sun Valley Company had worked with the legislator. You may remember Senator Robbie King Rudia, who's from Elmore County, because Sun Valley County was frustrated because there was a part in the rules that required a lifeguard if you had 35 or more bathers in the pool. And their frustration was their pool closes at 10 o'clock and at 9:30, just 2 school buses come in with the basketball teams and they all want to use the pool and they can't wave a magic wand and have a certified lifeguard, which I get, right? That's logical. And we had hoped to, because I actually worked for state public health at the time, hoped to be able to kind of negotiate and say, well, maybe let's just take that part out of the rules and keep rolling. But there were some circumstances that didn't allow that to happen. So fast forward to today, House Bill 202 it was a very lengthy bill. In fact, we reached out to the pool operators to give you some data today, like what are they thinking? No one knew that this was included in this bill. It was just an authority that the Department of Health and Welfare Director had that Director Adams wanted removed. So basically that's how this came about. So as of July 1, no pools of any type will have any type of government, local public health oversight. Now, one of the things I've heard said was, well, you don't really have very many drownings or no drownings in public pools, which is for the most part true, although we have had them occur. We've had some really significant outbreaks occur. We've had chemical burns, we've had cryptosporidium outbreaks. More recently, we had a Legionnaire's disease outbreak at one of our gyms that put people in the hospital. One individual, according to the news, was in for 8 days. So drownings are a bad outcome, but there's a lot more to recreational water. There's injuries that generally don't get reported. So I feel pretty strongly that it would be worth our time exploring options, possibly even to look at the high risk pools, which are where we get the most complaints and where we see some of the outbreaks occurring are in the currently unregulated. And then you have the public pools, and they often will do a good job. But when you have certain things like cryptosporidium that starts to spread, it finds its way into public pools, even if they're really well managed. So no matter what we end up with, we're going to have a fractured system, either no regulations anywhere in the state, or health districts will, like we're going to talk about in a minute, take this on, and Curtis will explain our preferred plan. With the board's approval, we'll go down that path. So just wanted to provide some context and where we are today, and Curtis, take it away.
Okay, thank you, Russ. Mr. Chair. So many of you may remember my presentation back in December where we discussed pools and some of the upcoming legislation that was surrounding it. That has really come to fruition, as we've seen now with House Bill 202 being passed and signed by the governor's office. It really makes Idaho the first and only state in the nation that we are aware of, according to our research, that has no regulation now as of July 1st regarding recreational water and public pools. So putting us in a precarious circumstance where we do maintain and still have the ongoing risk that we have always had, yet losing tools and ability to address that with the pool operators and the public. We have reached out to a number of our pool operators. We took a look at the 36 regulated pools that we do work with. We reached out to each and every one of them. We had several of them return responses to us, just trying to find out what their perspective was on this and how they felt about it. As Russ had mentioned, the interesting fact was that nearly every single one of these operators were not even aware that this type of deregulation of their industry was occurring. And remarkably, we haven't had any one of them return a response to us that indicated that they were in favor of that. And so as we look at some of the options that we have going forward, what we would like to do as a district, what we would like to ask is for your recommendation and your advice to us as the health district on how you would like us to proceed. Do we want to then, therefore, just as of July 1st, not have any presence in the recreational water industries and not have any ability to train, educate, assist pool operators with the safe operation of their facilities? Or would this board direct us to take a different approach and work with our municipalities within our 4 counties, the counties themselves, the cities, to provide some mechanism or some way for us to maintain some basic level of public safety and health in these recreational waters? And so that's kind of the discussion that we'd like to have today, and I'd like to hear your input and guidance on, so that my team and the district as in general has some specific direction and guidance from this board. So please feel free to ask me any questions as I kind of talk through some of these different options and some of the things that we would like to do. Most notably, we've reached out to all of our major cities that are operating pool facilities and public facilities: City of Boise, City of Meridian, Treasure Valley YMCA, and then probably the largest facility that we have in the area, Roaring Springs. All of those operators indicated to us with similar language that they value the relationship that they have with us. They value the inspections that have occurred routinely for the last several years, that we work together. They value the training that we provide, and they value the education that their staff receive from us. They look forward to us coming on site annually to investigate their water quality, making sure that their pump stations are working correctly, that their chemicals are mixing correctly, reviewing their logs, and doing the things that we do to ensure the safety of the pools. No one that we've contacted expressed any kind of willingness to forego that or wanting to abandon any of those partnerships that we've developed. So that was encouraging to us, that it is a valued service, and it is something that none of them wanted to do away with. In fact, Roaring Springs indicated that, according to their statement, that they would still have to contract with a third party to inspect, test, document that their pools are operating correctly if that role did not fall within the jurisdiction of Central District Health. So they would still, even if we weren't doing it, they would still be looking for someone to do it, and likely having to pay greater amounts of money than what they would be currently paying for in our pool inspections, which are nominal and don't even cover our cost. So moving forward, I think the recommendation that we would propose and that we would look for guidance from the board from is, what do we do going forward with these pools? Do we just not do anything and let them be as they are? Or do we take an approach where we start to engage with the municipalities within our district, our cities, our counties, in looking to pass ordinances that then set some kind of standard in the way we approach the education, training, and deliverance of a safe and effective pool system within the counties. Some of the options that we've looked at would be, we would work directly with like City of Boise, City of Meridian, different cities in the districts to adopt such things as the Model Health Aquatic Code. This is a national standard produced by the industry in coordination with the Center for Disease Control that outlines the safe operations of pools, exactly what kind of diseases they're trying to prevent, the things that they're trying to stop within the pool settings, and really promoting that safe model aquatic health facility as being the standard of operations. We would be able to adjust and modify that as needed, but really working with our operators to move fully towards complying with that, and really instituting that as the safe standard that we would like to follow within all of our pool regulations. And then working with our cities and counties to seeing that as being kind of the standard, and identifying Central District Health as the entity that would help then teach, train, and help to enforce that. So those are some of the things that we're looking at. I think as we look at what types of pools we would like to regulate, as Russ had talked about, we'd started out with nearly every pool in the counties being regulated at over 200 pools, down to a number around 36 pools that we regulate today. Those were classified into type A pools and type B pools, and we went into a lot of that detail back in December. But I think as we look at this from a public health perspective, and we look at where our highest risk is, and what type of settings produce the highest risk, we're probably would want to develop guidelines on addressing those settings in particular. I think as we look back at our most recent outbreaks of Legionnaire's disease, typically occurs within pool settings in gyms, and hot tub facilities within gyms. And so I think those are places that we would like to look at bringing into how do we implement this model aquatic code into those settings. I think as we looked at cryptosporidium outbreaks and some of those places that occur typically in public pools or in splash pad settings, where they're open air environment, open public, typically in parks, in areas like that are just available to any, including the wildlife frequent the areas. Those are high-risk situations that we would like to be able to step in and train and educate and assist with the operation and safe maintenance of some of those facilities. So I think as we look and think about moving forward with this, a couple things to keep in mind is, one, we don't want to come in and heavy-handedly regulate and shut down things. That is not the intent whatsoever. The intent really is to partner with our operators to create safe, hazard-free and easy to maintain facilities that are viable for our kids to recreate in and for our families to enjoy within our Publix settings, and for our operators to be trained, educated, and aware of what they can do on a day-to-day basis to maintain those settings in a safe way. That is really the intent behind it. We would like to partner with our cities, our city councils, our county commissioners to develop common sense regulations that make it easy for us to achieve those outcomes and really approach that in a way that is best for everyone, in that we're reducing the spread of disease and enhancing the ability for people to recreate safely. So I'd stand for questions or any comments if you have them.
Chair, in my past life, I had full operator experience, and I'm pretty disappointed that that burden has came off the health and welfare. But I do have to say, as a pool operator, that we never viewed them as somebody who regulated that. We always looked to Central District Health for the education. Always. There was never any question on who managed that. So I think that burden, if we do take on that burden, because it is a burden, I don't know how much it's going to cost extra. I mean, you already have the 36 or whatnot, but to add to that, but you are correct. That has been always a working relationship with Central District Health. It hasn't ever been shutting people down or anything like that. So I think that impression would stay. And I am kind of concerned that if there is a lapse after this July, that may be, that interpretation might be changed, that, it's off and then now they're back in heavy handedly. So I don't, in my opinion, it would be better to just, at least with the ones that were regulated or that are regulated now, to continue that service, and then there wouldn't be that negative aspect. That's just my personal.
Mr. Chair, we are going to do our inspections, because the good thing is the timing on this, all the pools will be open before July 1. They've already paid their $50 annual permit fee, so get that done. Made that commitment, and just a little more recent background is we asked Department of Health and Welfare, could you pause on making this particular change this year and give us time, and talked about the executive council that Betty Ann represents this board on, and apparently that wasn't an option they were willing to consider.
Because the pools themselves are used to CDH helping, and especially Roaring Springs and some of the bigger facilities. I mean, common sense would dictate that they would have liability if they're not consistently inspected. Isn't this just something we could go out to each of them and say, look, we're still here to do this, and we're willing to do this, and it's going to cost you less than the private market? And I don't want to go to a public pool that doesn't have quality inspections happening. And I'm sure if the public knew that, the state changed this, that, I mean, to me, it's just common sense that these pools that we already help, like Crystal said, would want that continued partnership. And I think, better than Central District Health. So, in spite of the change in regulation, I still think it'd be common sense for all of these operators to continue the relationship. I just think it's a public education thing. Hey, folks, here's a pool that you can swim in whatever, but if you go to it, you're not swimming in whatever, I think the public would be more inclined to trust where they're going.
What was the appetite from the municipalities to have? Were they gung ho to pass a specific ordinance, the cities, or what from some of our commissioners? if you do it county by county, what is the appetite for a policy, a county-wide policy? I mean, did you investigate with the cities?
Yeah, Mr. Chair. So we've contacted pool operators from each of the cities, City of Boise, City of Meridian, Treasure Valley YMCA. All of them have indicated that they would be in favor of continuing a partnership with us and working in some way. Now, that doesn't necessarily mean that their city councils would approve that. We haven't gone to that level of work yet. I know some of our counterparts in District 3 out of the Caldwell office have started some of those conversations with some of the city municipalities who have generally indicated that they would be willing to have those discussions and that direction if there was no other oversight from a state level. So I think that there would be an effort and a will there to pursue that. In additional, Russ has spoken with our legal counsel trying to develop some guidelines on how we would proceed with this. Working with counties, we would love to engage with counties on that. However, counties passing ordinances then would not necessarily apply to things within city limits. And so we would have to then work with cities to approach what we would like to then do within city limits. However, we do have a number of operations that are within counties, but in the unincorporated areas of counties that don't fall within city limits, especially in some of our more rural counties. And so looking at all of those different opportunities and being able to partner for the educational purposes really is what we're looking for. We'd love to be able to work with our cities and our counties to develop some type of resolution like that, where those entities within their jurisdictions are working with us as the expert on pool regulations and operations and following the model aquatic health code and ensuring that the public has access to places that we all feel comfortable recreating in versus whatever being got filled with water that people are in.
Stock take.
Which is
So
Yeah.
can the health district,
Exactly.
can the health district adopt that standard that you mentioned and apply it through the whole district, or does that have to be adopted by the underlying entities and then the health district manages the standard?
Mr. Chair, good question. And yes, I would love to see this board adopt the Model Aquatic Health Code kind of as the standard of operations for pool facilities within the jurisdiction. I think it would then become the direction of this board to direct us on what rules that may apply to, and to what extent we want to train and educate operators on that Model Aquatic Health Code. I think we would still want to work with our city entities and our counties on trying to develop the right balance between every single hotel, motel, and apartment complex that's got a pool versus the most high-risk settings that need to have some type of oversight where we're avoiding things like outbreaks of Legionnaires that puts residents in the hospitals, and cryptosporidium problems at splash pads that are open to any and everything.
Mr. Chair, I wonder, thinking about this, what, kind of heading down the ordinance path at the city level or possibly counties, I think about Terrace Lakes. I don't know if they're in an incorporated city. Then you got Silver Creek area. That's definitely not.
That's
I wonder, just knowing we're going to inspect the 36 pools before July 1, so we'll be able to do that this recreational water season, is to give us a little bit of, probably the real question is, do you want us to go forward and develop some plans, some proposals, work with the businesses, work with the cities on some type of regulatory oversight for swimming pools, or do you want to let it go on July 1? And then if you say yes, there's not a decision, it's going to be a process now. And we have some time to get this right and to do it in a way that our pool operators of various types value and go from there. Because if we can adopt you all can adopt rules, but that's a rulemaking process that ultimately ends up with the legislature. And I don't know how they might respond to individual health districts regulating and other health districts not. I mean, that was the whole point of having this done at the state level. In fact, the health districts, even though it was the director of health and welfare that had the authority, it's delegated to the health districts statewide in rules today to do what we do, not unlike food establishments and air and septic systems and everything else we do. It's often given state authority because that creates consistency statewide. What you have now is you'll have a fractured system, which we will have no matter what, because this law is going into effect on July 1. When you'd be talking about if every city, including Cascade, passed an ordinance, you'd have hundreds that would have to be implemented statewide. So anyway, lots of commentary, kind of very interested in this subject. Is what would be helpful is just if the board would like us to proceed exploring options, working with our community partners, including cities and the operators, to develop some standards and then figure out what, work with like Mike Kane to figure out what is logistically the best path to get down to make this work.
Mr. Chair, I don't think we can call ourselves a public health board if we let this just go by the way. We have got to follow, and there's models out there already. This is a big deal, especially if you're in a clinic or an ER and get hit by all those sick kids. Diarrhea. It is a big deal.
I agree, especially being in a tourism community where really the rec center is a major part of our tourism for Cascade. And if, it's unfortunate that this was passed, especially without much of the grassroots people knowing. So I think it's extremely important to continue with.
I've got a quick question. How do they get their insurance if they're not inspected?
Mr. Chair, that is a great question. I don't know what impacts it will have on their ability to obtain insurance or maintain their insurance, but that one of the comments from the director of was that their private insurance companies will regulate them sufficiently. I don't know that that's necessarily the case, and we and the pool operators have very clearly expressed that they value the partnership and relationship that they've developed with Central District Health to provide the education, training, and oversight that they need to be able to effectively operate a pool of reputable station. So.
Sure, I mean, just from a common sense public point of view, if I were the pool owner, I would want on the wall, we meet these standards. And, if we set that standard or help set that standard, action, we can say, hey, this pool meets this standard. As a parent, I would obviously favor those facilities that meet the bare minimum. This is not a stock tank,
Mr. Chair, just in conclusion, I'd like to share some of the information that was shared with us from our pool operators. So this is from the aquatic manager of the city of Boise. They said, we value the Central District Health mission and would be in favor of supporting Central District Health as a resource and utilizing the service that would be made available. It is our preference that these resources remain available, and we will collaborate in continuing to keep pools regulated, inspected, and provide available training that is necessary for the safety of our customers. YMCA, this is the CEO of the Treasure Valley YMCA, has stated that we have had a long and productive relationship with Central District Health and appreciate the expertise and care that has been taken to ensure that our pools are operating at a high standard and safe for all, regardless of age or health status. public safety is an essential role of government, and we believe discontinuing oversight would be a mistake, as it plays a crucial role in protecting a significant portion of the public. And then also from Roaring Springs, the CEO of Roaring Springs, who has indicated that that regardless of what happened, that they would then seek to continue to contract with a third party to inspect, test, and document that our pools are operating correctly. So I think they're indicating regardless of CDH's role, they would still be looking for somebody to provide that type of guidance for them. So.
Mr. Chair, if this were to, if this pool inspection thing was to go by the wayside and the ultimate consequences that we know are going to happen, they're going to point their finger. They're going to point the finger at us.
I might offer that nothing prevents an individual pool owner from self-adopting the standard and complying with the standard to get that public seal of approval also. And a lot of nutritional supplement companies, for instance, will offer their product for third-party testing and that sort of thing, and they'll want that seal of approval, and they'll make sure they have it in that regard too. So nothing precludes self-compliance and self-meeting a standard either.
Mr. Chair, just speaking of what Betty had just described, not only healthcare, but when people get sick, it's other staff on Curtis's team.
Yeah.
The disease investigators that go out and figure out what went wrong and to do all the public education. So that actually it shifts the burden, from a regulatory education to, oh, we got a problem. So, I put it as an action item, but you don't have to take action. You can just say, yep, go forth and explore. And I think that's what I'm hearing from all of you. And then we can bring this back at future meetings. I don't know how much we'll be able to get done between now and April 18th, probably not much, but maybe by May we'll have more to share and just keep advancing this, and we'll keep you informed if that sounds okay with what it's not just what we want to do, but what the community is interested in, and then meeting the businesses themselves, as well as our cities in particular, and possibly Boise County.
Chairman, I would also say that Kurt's maybe, I know you guys are busy, and quicker the better. That way, when you do those inspections, you can say, hey, this is what we're proposing.
Yeah.
We're going to be doing leadership, so that they kind of have a heads up that we're not leaving you hanging.
Yeah.
You're going to have an option. And if you're, if your leaders so desire, then we're going to be there for that. That way they kind of grease the wheels. If you can get it done that fast.
Yes. I can attest the ducks are flying through right now, and they like those pools. So I think moving forward is a good idea.
I just got to add, my neighbor has a pool that she put in. She had, we live in a rural area, a lot of wetland area. So she covers her pool. Had a heavy rain, so the ducks were swimming on top of the cover of the pool.
And we have a pair named Dick and Myrtle. They fly through every year. I don't know. Salt. Already landed. I'm not swimming until we open the pool and clean it up.
All right. So what I'm getting the sense is that it's worth investigating. And I think just giving Curtis some leeway to kind of continue to gather and maybe refine some possibilities. It's a huge situation, really, which pools get regulated. We went from a bunch or a lot to a few, and then now none. And so I think that for now, we don't need an action item.
Yeah.
Everybody agree? And we'll just continue, get a little more information, see what additional Curtis can come up with.
Mr. Chair, agreed, and that sounds great. We will send the team out and see what we can figure out.
Okay,
Thank
very
you.
good.
Thank you.
All right, next, little behind schedule, but director's report, Russ.
Okay, job. My report's usually pretty brief, but will be today. So there's a couple things I just wanted to share with you that Betty Ann's one of them is very familiar with is the executive council, which is an elected, you all elect the chair, vice chair, and executive council member, which will actually happen at the May meeting. Betty Ann is the executive council member for Central District Health. Each health district has a member, and what they typically do will be meet pretty frequently during the legislative session, tracking anything that might impact public health. At the October meeting, which some of you were able to attend in Idaho Falls, there's a SWOT analysis done, strengths, weakness, opportunities, threats, and Idaho Association of Counties, Seth Grigg helped facilitate that. And from that, there's conversations happening now with the executive council about whether or not the Idaho Association of District Boards of Health should continue to exist. So there's this draft ballot that's not yet ready to come out to all of you. The executive council is still discussing it and some of the language in the ballot, but it's more of a heads up. And of course, I'll likely be the one to send that to you. So make sure that you get it. You have the opportunity to vote. And right now, there's just two questions. Districts will rotate the responsibility of hosting an annual meeting, which is exactly what happens today, or option two is dissolve the association. So, and I'm not sure, I think, you all meet every Tuesday, most every Tuesday. And I don't know if you want to share anything about that.
Yes, I do. I do. And I'd like the board's direction on this. I've been involved in the meetings with the state association in the 7 districts for some time now. And I really think there's a great value in the solidarity of the districts. If we go off and dissolve that whole thing and say District 1, Boundary County, they want to, go off on some rogue idea. Or if we have an idea that we feel is worthy of taking to the legislature and possibly putting into code, we're only one district. We need to have that solidarity. We have, most of our problems are common problems. However, we do have geological differences. So I am very much opposed as personally to eliminating that communication. And it wouldn't have to be necessarily an expensive get together where we're traveling and all of that. We could even do, virtual meetings, but I think we need to maintain that. So if the board directs me to do otherwise, I will do otherwise. I'm open to hearing your ideas.
Chair, I think you bring up a great point, Betty Ann, is in terms of cost, and if we're going to have to be cost conscious budget wise, each district has their own funding and needs. I mean, virtually is what the world is doing now, but getting together often enough to hit on those commonalities, that's where sometimes I say no one of us is as dumb as all of us, but at other times in these meetings, you'll find ideas that nobody else thought of. So I think it's a good idea at least to maintain the communication, even if it's virtual.
Has the association been very effective at driving legislation or resolution of shared interests over the years?
It's lost on pools.
Yeah.
Well, but with the association, how involved were they and how?
I can answer that if you
Go ahead.
like. So I think there's opportunities for improvement in that area. The challenges that we've had in the past, which was somewhat helped by the change of the meeting timing, because it had always been in early June. And then the legislative session is so far away, any ideas you might be talking about or legislators you're talking about in relation to public health, it's often too distant to have those discussions. This past year it was in later in October, which you participated in. So you're a little bit closer to policy time. Personally, I think the local boards of health, there's 54 of you members, have a lot of strength in numbers, and I think it's around 65% are county commissioners. And if I could change something, I would suggest that we do decide, like most associations do, what is of greatest priority, just like the Idaho Association of Counties, those of you are commissioners, they set their priorities, and that's what those Seth and Kelly Brassfield, they work on that, either in a defense mode or trying to create new policies that will be beneficial to whatever the interest is. And we've not really done that in an organized way, except for a couple times we did, where Mike Keene happened to be hired to push bills forward, and they were around food establishment fees. And it's not free to have that done, but the benefits are, in that case, it was revenue, is significant. So personally, if I could give any advice to the association, it would be like, when you guys get together in October, besides having people come in and present, think about what is it that you want to do, and then put some money behind it. The nice thing is it's shared 7 ways. It's not going to be one district's budget. And get somebody in the legislature who will actually actively represent the public health district. So when the pool legislation comes up, that person has guidance on how you all feel, like you feel this is a good idea or not a good idea. And then they can push for that one way or another. And I think that's what's really been absent, except for a few times.
Yeah, well, we pay IAC to represent us, but we don't get that representation.
No, they have their, they have their priorities set by the counties, which is their primary responsibility. And we're sort of this entity out here on we pay our money or pay them per year, and they keep us informed, but they've never really actively lobbied on behalf of either for or against legislation. So,
and I don't mean to seem crass, but I have a problem with the quality of keeping us informed. That's the way I feel about it. They're either absent, they don't show up, or they don't know.
I think we benefit the public health system of Idaho, the local public health system of Idaho would benefit from having a voice during the legislative session. And also in that October meeting, assuming it does happen, that the association doesn't get dissolved by way of vote, that we focus on that. And I think it's going to require you all to say, hey, this is what we'd like to do going forward, so that we are more effective in doing what boards of health do, which is protecting the health and safety of our communities. So the executive council is talking about this ballot. I think if it gets approved, then it'll be sent out to every member. So you all will get a chance to vote. I don't know exactly when that's going to happen. Sometime it is in the next couple of weeks, and you'll get an email from me to fill this out. The DEQ MOU, we talked about the health districts, all 7 of us, the desire to remove ourselves from an MOU, because it's not in law or rule, from the regulatory oversight of non-municipal private solid waste sites. That has been communicated to the director, Director Byrne of DEQ, and he's in the process of reviewing it with his staff. So just wanted to give you a heads up on that. Maybe by April or May, we'll have some more information to share. It's kind of a unique situation. It's not like contractual, no money's changing hands. So we can remove ourselves. We just like to do it in a cooperative way and make sure they understand why, and get their buy-in. So that's in process. For April, I invited our WIC program manager to come share about the WIC program. Beth talked a little bit about some of the challenges we're facing, and our numbers have been steadily increasing instead of declining as they have nationwide for quite a long time. So that's exciting, other than we're short-staffed, to be able to meet the demand. And so I wanted to ask too, for in addition to that, in May, as far as staff presentations, is there any other topics for April or May that you would like to hear from our team?
We haven't gotten an update on the employment or the employment ones that have left, like an update as far as those cases are concerned.
You mean the annual survey?
No, not the ones that disgruntled, that are.
Yeah. So all resolved.
Oh, perfect, okay.
Yeah.
Okay,
I can
okay,
share more, but yes. Well done. No more pending.
okay. We don't need to add that then.
Yes, as data continues to come out, I know there's still some public concern about the COVID injections still being in both districts and whatnot, and other districts have set examples. And I know there's some groups that would like to share public commentary in that regard. So we could potentially consider that on the agendas.
Okay. So just speaking of that, what no matter what the topic is, I know you all had, I think it was 5G, the 5G network individuals came in. So when I get contacted, I always offer them the opportunity to come in, and we have a public comment period, and as many people as would like to come. I know there was more interest during the pandemic. We had several testify, and more recently we haven't. But so yeah, anytime I'm contacted, if you prefer I do something different, glad to do that. But so anything else you'd like to hear about?
Russ, I would like to share this letter that I received yesterday, if that would be okay.
If it's a good one.
Well, this actually pertains kind of to the executive council, which my name is, I'm not sure I'm pronouncing this right, Alejandro Nicochea. Is that close? Okay, sure. I am an internist in Boise, and I'm also chair of the Idaho Medical Association Public Health Committee. I am writing health board members across the state because I am concerned about House Bill 135, a bill that might go to the Senate floor for a final vote this week. It imposes citizenship verification requirements for certain benefits like immunizations, testing for communicable diseases, prenatal care. So this is a public health and medical, from a public health and medical perspective, this is a big risk for us, because if we have an illegal come in that's sick, and we have had, as far as syphilis, tuberculosis, we cannot test them unless they have citizenship verifications. Now, disease doesn't care about that paper at all. So you see the problem there. If you could weigh in on.
I thought under all laws that no matter what, they have to take all comers.
Well, this House Bill 135 says if they don't have citizenship verification.
Most of those things are required reportable diseases anyway.
Yeah.
That's a public health risk.
That's a bummer. So you might contact your legislator on that. Do you have any further input on that? Yeah, wow.
Disease surveillance is important.
I've got to read the language of that in a little more detail.
House Bill 135.
Yeah, did you actually read it?
The bill.
Verify the
Yeah.
language.
Yeah, I appreciate you sharing it. You reached out to me also, and
I have an update. The three of us, at least for now, get to stay because we don't have a elected official mandate for health district boards any longer. Bill was defeated
All right.
in the Health and Welfare Committee a couple, 3 weeks ago.
Proposal was to require all board members be elected
Officials.
so that failed. That's another good example. If you had a voice there, I mean, it could have passed. And if it did, we would have learned that today. It's like we didn't necessarily know.
Had it passed, the three of us are done on June 30th.
Yeah. You would get to stay because you're the physician representative. That was exempted out of the, yeah, so. And I'm telling you, there are bills every single legislative session that I think, again, I think it'd be worth having somebody there to represent the health department. And we don't.
Well, I think Mike has been very fair and his fees and everything.
Yeah.
But we're just not getting our dollars worth from IAC in my humble opinion.
Do we budget any money for, say, Mike Kane or somebody like that? There's, or not, or your accomplished.
Mr. Chair. So what has happened in the past is the association budgets for that. And then we get an assessment that we have to pay into that. Basically it's managed by Public Health District 2, just by virtue. They said, we'll agree to do that. And then they would pay those invoices. So in the past, when we actually have had Mike be a lobbyist for the health districts, you all, along with the other members, got to vote on, yep, let's set aside this amount of money. We agreed to have that be assessed against the district. And then as legislative session moves on, District 2 will pay those invoices. But to Betty Ann's point, I mean, it's been a while, Mike and I worked on legislation back in 2010, the fee revenue legislation, and I can't remember the dollar amount, but it was not much. It's not like $100,000 or anything like that. It's a pretty, and he charged us just a kind of a flat rate monthly fee. So, and I know there was discussion in October. Did we talk about that at all? Wasn't there some discussion around lobbyists on the budget? Yeah, so I don't know what it will cost, but I think it'd be ideal for the association to say yes, and then it's split 7 ways by the 7 health districts. So it greatly reduces our cost if we were to go on our own. And then going on our own, I'm here representing Central District Health, and sometimes that gets translated to Ada County. Not that Ada County bad, but just that you're better off having the rural voices and a statewide perspective. That's all I have.
You're wrapped up.
Yep, thank you.
All right, very good. The last thing then is public comment. I don't see anybody in here that isn't usual. And I'm assuming no virtual. All right, so in light of the fact that there doesn't appear to be any public testimony, thanks for putting up with me. You're adjourned. I dropped it.